Hello, everybody. This is Sarah Hashmel from AIDS United, and I would like to welcome you to today's webinar, Supporting HIV-Focused Community-Based Organizations and Contracting with Payers. This webinar is in listen-only mode, and it is being recorded. The recording will be made available on the AIDS United website either later today or tomorrow, and you will receive an email when that recording is live. As a reminder, you can listen via your computer speakers, or you can call 1-866-740-1260 and use the passcode 876-2819. If you have any questions, please use the little blue chat icon on the bottom of your screen to send us a question, and we'll get back to you. With that, I'm going to turn it over to my colleague, Zach.
Hello, everyone. This is Zach Ford with AIDS United Sector Transformation Program. Thank you for joining us today for our webinar. This webinar will last approximately 1 hour, and it will include time for question and answer at the end. Today's webinar is the first of several we have planned. We are partnering with the Menzies group to offer a webinar series on the topic of monetization. We will host one webinar per month on a different topic and toolkit that Menzies has prepared. This webinar series will also include free one-on-one coaching with the Menzies group on a first-come, first-served basis. Specific details and additional information will be made available soon. Please sign up for AIDS United emails or visit aidsunited.org/webinars to learn more.
So I'll go over this slide, and Mo, you can chime in if you're not seeing the correct slide, but we're going to cover an overview of AIDS United. We're going to give a toolkit project background. You'll learn about managed care landscapes. We'll cover some case studies and contracting mechanisms and considerations, and then finally we'll cover key policy recommendations, and there will be time for Q&A at the end. So again, this is our mission. We're a national nonprofit organization with a singular mission of ending the AIDS epidemic in the United States. And Zach, I'm going to turn it back to you.
Sure. So at AIDS United, what we do, we lead the charge for responsive and effective federal, state, and local policies that benefit people living with and at risk for HIV. We invest in innovative models to meet the needs of communities affected by HIV and AIDS. We have given more than $104 million in direct funding, and we've leveraged $117 million to increase capacity of communities and organizations responding to HIV in the United States. And we inform the field with best practices and lessons learned. How do we do this? We advance advocacy based on sound public policy, strategic grant making to affected communities, targeted and tailored capacity building for organizations responding to the epidemic, and research and evaluation to inform the field. We work within a social justice framework that challenges the foundational issues of racism, sexism, homophobia, and transphobia, socioeconomic inequality, gender discrimination, and stigma. So this webinar is being funded by Sector Transformation. Sector Transformation is a privately funded grant-making initiative that is generously supported by Johnson & Johnson. Sector was designed to help AIDS service organizations and community-based organizations respond to changes in federal health policy and HIV funding. The Affordable Care Act, evolving funding streams, and new paradigms have increased the focus on biomedical approaches to HIV and integration of services with broader health systems, and Sector Transformation seeks to assist organizations facing these critical questions, opportunities, and challenges. So thank you all so much for joining and listening about the AIDS United overview. With that, I will turn it over to the Menzies group.
Hey, thanks, Zach. This is Joel Menzies, and thanks for the opportunity to do this project work. In consulting, you don't have control sort of over who your clients are and what you get to work on, but being able to support what you guys do and your members' missions is a privilege for us. So we're very appreciative, and for the ongoing webinars that'll go on the rest of the year as well. We're excited about that. Let's see, slide 10 is just a photo op. We were traumatized when you guys asked for pictures, but we did scare up a couple of Thai photos for our boys and Wannapurnima. So hopefully you'll stay with us past slide 10 now that you've seen what we look like. Slide 11 is just walking through a background on just what the project was, but the essence of it was that the HIV community-based organizations are in fact doing a great deal of care coordination, but they aren't very often doing it under contract with the payer community. And as funding streams evolve, sometimes adversely for the HCBOs, the community-based organizations, AIDS United felt it was important for their members to avail themselves of whatever skill set and knowledge and techniques are known to exist out there to try to play in the regular, if you will, contracting or creative contracting environment with the health plans and partner with them rather than kind of operate in a side sphere independent of the payer community. So that created the project, and the rest of our presentation, and in fact the webinar series that's coming up the rest of the year are all focused on different techniques to just try to create successful partnerships between you guys and the payer community. We certainly think there's a lot of opportunities for so-called win-win arrangements to occur, and we're trying to help that along and as best we can from sort of a general perch in this. But as Sarah said, we are also making some one-on-one consulting available through the rest of the year. So we're looking forward to fielding your requests for that. The project work we did zoomed in on 4 specific community-based organizations. I'll name them on a soon-to-come slide. And we tried to look at what their situations were and convey, and in some ways try to think about how, informing the toolkit, how we could help those entities. And those entities were hoping that what they were doing and what we were doing with them would have broader application to the rest of the membership. And we hope that's the case. By the way, this is all on all of this information, the toolkit and the report we did are all available at AIDS United's website. We can give you that, letter by letter at the end of this, if that's helpful. And as Sarah said, we are taking questions, I think, in writing during this call, and the question and answer, I think, process is for you guys to submit them in writing, and we'll try to field those when we hit a break point before Mo goes through the toolkit itself. On to slide 12, this is just talking about funding sources. It's not directly associated with the toolkit work we did, but one thing I'll just say about the numbers on this slide, Medicare is one of the key public sources of funds, or the largest key public source of funds for HIV care, and research funds are also kind of baked into the numbers that are in this slide. And Medicaid is smaller than Medicare by roughly half, but in my view, I think a lot of your guys' best opportunities or biggest opportunities are going to lie on the Medicaid sector. Only a third of the Medicare population is enrolled in Medicare health plans, and over 70% of the Medicaid population is enrolled in Medicaid health plans, and over 50% of all Medicaid spending is capitated, and in I think 5 states, over 80% of Medicaid funds are capitated. And whereas Medicare managed care contracts, where CMS contracts with a very large number of health plans in each county, in the bigger counties in the U.S., there's an average of 25 Medicare health plans in each market before you even get to Medigap and other kind of Medicare-related policies. The Medicaid program, state Medicaid programs, are typically contracting with an average of 5 or so health plans. So there's a larger population funneled to a much smaller number of health plans for you to partner with on the Medicaid side. and they're facing procurement challenges, and they want to be one of the 5 and win one of the slots, and that dynamic creates partnership opportunities for you, and Purnima will get into that in a minute. On the next slide, I just wanted to name and sort of thank the organizations that helped us last year with the project work we did. These are AIDS Foundation of Chicago, Cascade in Portland, Crescent Care in New Orleans, and RAIN in Charlotte, North Carolina. And that latter entity, RAIN, is now in the midst of, I think, having some conversations with payers because North Carolina on the Medicaid side is flipping from a completely fee-for-service environment in Medicaid to a almost completely capitated program. So this is kind of the moment in time for partnerships to be arranged in North Carolina, or a very opportunistic moment, and RAIN's involved in that, just to single them out in that way. But all of these organizations have either have relationships in place with payers or have been working towards that, and hopefully, the work we did with them is of some, ongoing benefit in their efforts. With that, I'll turn it over to Purnima, and she'll go through a few of the next slides.
Thanks, Joel. As Joel mentioned, over the next few slides, we'll describe elements of how to effectively partner with MCOs. The first layer of this is to understand that where HCBOs have skills, MCBOs can and do look to leverage so that they can meet their contractual obligations to the state in managing healthcare total cost of care. Probably a term that you are hearing is, the bingo lingo, and the quality of care for their population, again, especially in Medicaid. To achieve this, MCOs have to demonstrate an understanding of the community, again, that HCBOs have established, that you guys as AIDS United member organizations are very good at, demonstrating that they can reach and locate their hard-to-reach populations, again, that HCBOs are the ideal liaison for, demonstrate an ability to effectively manage and engage in costly ARV therapy, again, that HCBOs are well-positioned to support. And they need trusting liaisons to support care coordination programs for high-need populations, including those with HIV, but not limited to only serving the HIV population. I think one thing we've learned is many of the HCBOs we worked with have expanded their scope and are very well adept through the serving the individuals in populations with HIV that you're serving, have also learned to serve other high-risk populations that managed care organizations are desperately trying to figure out how to get their arms around and support their well-being. Okay. Mo, would you mind forwarding to the next slide? I think my thing is stuck. Oh, there we go. Thank you. Okay, so some key challenges that we identified through information provided by the case study HCBOs are general lack of understanding of the contracting process for these types of programs. It's a new playing field for some HCBOs. Second is demonstrating the HCBO value proposition. It's important to be able to clearly describe what it is that HCBOs are offering, and I think the items within our toolkit try to lay out some steps where you can achieve this. And then third is access to information MCOs have to fully coordinate care. This is a challenge within the contracting process as well as post-contracting to make sure that there's some form of data sharing so that the program or the pilot that's implemented is effective and that HCBOs have the data at their fingertips to address their members. These are all items that we try to describe in further detail in our report, and we also try to engage with HCBOs in our case studies that we worked with last year in really understanding and identifying if there's a semi-solution in the contracting process to address. Next slide, please. No, thanks. Okay, so this slide lists some contracting steps for consideration. First, identifying MCOs or payers that cover populations HCBOs are interested in serving is one of the first steps. Again, we have a toolkit. One part of our toolkit actually tries to list some ways to identify MCOs The second is proactively reaching out with your value proposition and contracting. So it is, again, very important to be able to describe what it is that you can offer to a payer. And again, our toolkit tries to achieve that and indicates where it is that states are, MCOs are contracted with states and the obligations that they are required to meet with the high need population. And so understanding that and identifying where your strengths are that really will make MCO stand out is a win-win relationship. And so it's just a matter of identifying that area and proactively reaching out to them and describing the type of service you can offer. Identifying services to include in the MCO HCBO contract. So it's very important to get specific and explicit in contracts. This is something that I think all of the case studies indicated, and explicitly listing out the services and responsibilities is key. Creating a data-driven approach with a detailed pricing structure with value-based components for a pilot, and finally, tracking performance and adjusting the program as needed, just as you would want to in evaluating any type of program. All right, next slide. Thanks. Okay, so this slide reviews some policy considerations that are relevant and impact HCBOs. The first is the need for HEDIS and HEDIS-like quality measures in Medicaid and other programs that monitor adherence to ARV, engagement in treatment, and more. And while more and more states are adopting these, many are still not. The second point here is, in addition to having these quality metrics, MCOs are not always, depending on the state, of course, responsible for performance on these quality metrics. So quality metrics shouldn't just be reported. There needs to be some form of accountability and an incentive for them to meet or exceed state or national benchmarks. Third is the pharmacy carve-out of HIV meds. It actually can help eliminate financial disincentives for MCOs and push for better access to ARVs. And last, finally, advocating for use of drug formulary to steer towards the best regimen in terms of quality and cost of care. Okay, so the next slide is, I think, where we wanted to go to a breaking point and open it up for a few questions and answers if we have any.
Purnima, so I think we're going to save all questions for the end of the presentation.
Oh, okay, my bad.
All right, everyone. Hello, my name is Mo Hamden, and I'm a research consultant at the Menzies Group. As part of the report, our team put together 10 different resources to help HCBOs navigate the contracting process. And as we've said before, they are currently available on the AIDS United website. So I'm going to give a brief overview of the toolkit, and then I'll walk you through 3 of the tools in more detail. Tool A is a spreadsheet that lays out the Medicaid costs and utilization of HIV/AIDS prescription drugs, and more information on this is to follow. Tool B provides model contracts for Medicaid managed care HIV specialty plans. And so some states create specialty plans targeted at people living with HIV/AIDS or at-risk populations. And these model contracts tend to focus on care coordination and case management programs, which is a great opportunity for HCBOs to partner with the payers seeking to bid on these contracts. And we've included these model contracts to give you a sense of the services the MCOs will likely be seeking. This tool includes links to 3 state specialty contracts, but we've also provided PDFs of model contracts for Florida and New York State. Tool C is a spreadsheet that lists enrollment levels for each MCO in 39 states, including the District of Columbia. Most of these MCOs serve many people living with HIV and represent potential contracting partners for HCBOs. And generally, the overall Medicaid enrollment across different MCOs will serve as a reasonable proxy for the distribution of the Medicaid population living with HIV and who are enrolled in the MCOs. Tool D has a similar layout to the Medicaid enrollment tool, but includes Medicare Advantage enrollment from March 2017. So roughly 34% of all Medicare beneficiaries, as Joel said, are enrolled in MCOs through the Medicare Advantage program. The MCOs with large Medicaid enrollment likely have a sizable number of enrollees living with HIV, and these MCOs should be considered as contracting partners. Tool E lists the Blue Cross and Blue Shield companies by state. So if you're seeking to partner with a private health insurance payer, you will need to research the key entities serving your geographic area. We've included this tool because Blue Cross and Blue Shield often holds a significant market share among employer groups and individuals who have private insurance, so this tool should come in handy and save you time and effort as you research the market. I'll go into tools F and G in more detail shortly. Tool H is a specific document prepared for Washington State by Milliman, which is an actuarial consulting firm, and the document derives monthly payment rates for care coordination services and can serve as a useful tool as you begin to negotiate payment rates with payers during the contracting process. And Tool I is another cost price index tool with a focus on Medicare. And it includes fee schedules for all procedures and services related to HIV/AIDS healthcare. And then the last tool we have for you is a bibliography of selected articles related to HIV/AIDS care. Some of the articles include the impact of the Affordable Care Act on health insurance coverage of people living with HIV, creating a Medicaid supportive housing service benefit, financing HIV prevention services, among others. And as I've said before, we just want you guys to know that you will have access in there currently on the AIDS United website to this toolkit as well as the report that we've written. And so now we're going to take a deeper look into Tool A, which is a Medicaid costs and utilization of HIV/AIDS prescription drugs. This tool provides a state-by-state summary of Medicaid's prescription drug spending for all HIV/AIDS medications, as well as a brand generic utilization ratio. And then, as you'll see later on, there are additional tabs in this tool for each state, plus the District of Columbia, that provide a detailed account of all the drugs and their associated costs that were dispensed in Q3 of fiscal year 2015, according to CMS. So this slide right now provides a screenshot from the summary page. We've included the total number of HIV/AIDS medication prescriptions, the total units, which is the number of pills per prescription, the total cost of prescriptions, as well as the average cost per prescription for each state. And then we further broke this down between managed care and fee-for-service payment structures. And then right now I'm going to share my screen to show you the state-specific and medication data. And so right now you're looking at the New York State tab. And so we've included the NDC code, which is the national drug code assigned to each specific drug, taking into account the dosage. We have the drug name, the dosage, and then whether the drug is brand or generic. And then we've also listed the same information as we did on the summary page with the total scripts, the total units, total cost, and then we've also broken it down between MCO and fee-for-service. And then down here, we've included the total number of brand drugs and the total number of generic drugs for the state, and then as well as the percent generic. And as you can see, generic drugs are much cheaper than the brand name drugs, and this is why we believe it is important for entities like AIDS United and their membership organizations, why they should advocate for generic drug formularies within MCOs to help save on prescription costs and then utilize these saved costs towards actual care coordination and case management and other HIV services. Tool F, we put together a draft text of a sample introduction letter that you would send to a potential payer. And the text highlighted in yellow is where you would include the information pertaining to your specific organization. So the first half will include high-level information about your organization, so the number of enrollees you serve, how long you've been around, etc. And then the second half on the right will include the specific services you would offer to the payer as part of the contract. So these may include ongoing case management, directly providing meals or other nutrition supports, as well as medication adherence support. And then we've included at the bottom inviting the payer to visit your organization at your office. And we think this is important because it would allow the MCO staff to get a first-hand look at your care coordination and care management efforts. And while they're there, it may also be useful for you to provide de-identified case study examples of the services you're providing and the impacts being achieved. This will be important since the MCO will be able to get a stronger sense for the work your organization does, and it will explain to them better why contracting with you will result in major benefits for the MCO and their enrollees. And then within the report that's online, we've included case examples from our case studies, and this will be helpful to look at when identifying the types of information you'd like to present to the potential payer and kind of choose what's the strongest evidence of your work that will really help get the ball rolling with the contracting efforts. And then I'm going to share my screen again to show the cost and pricing derivation worksheets. So this worksheet was developed to assist HCBOs in establishing initial prices for their MCO contracting partnerships, as well as for assessing the performance within these contracts. And so in the first column, we've listed staff positions, and this was, so all of the information that we've included in these worksheets should all be altered depending on what you're going to be what services you're going to be contracting, and the financial aspect of the contract. So please feel free in changing all of this information based on your own circumstances. And so we've listed some of the staff positions that would be included in the contract: the annual salary, the benefits loading factor, the organizational overhead loading factor, and then in column F, we have the full cost that takes all of this into account. And then in column G, we have the fully loaded hourly rate. In column H, we have the target profit margin, and again, this should change depending on your own organization. And then the hourly rate with profit takes into account the target profit margin. And so the next tab has the same staffing that we've included in the first one with the fully loaded hourly rate and the hourly rate with the profit. And then we have these two sections over here, the initial assessment and then ongoing case management. So the initial assessment would be your staff meeting with the enrollee and kind of just getting an intake of what their situation is. And so we've included, so this column for column E would be the amount of hours per enrollee that you would utilize for each enrollee. And then we have the one-time cost associated per enrollee with and without profit. And then we have the same information here, except this is ongoing case management, and this would be monthly hours per enrollee, and then the monthly cost per enrollee with and without profit.
Yeah, our presumption here is that a lot of the contracts with payers are going to involve a per person fee for all of their enrollees who you would be delivering care coordination for. And part of that we thought would be a one-time initial assessment fee that's fairly involved, and part of that would be just an ongoing monthly fee. So the prior tab tried to get at what's an hour of labor truly cost once you load in the benefits and a reasonable operating margin for what you're doing. And then this second tab is looking at, okay, well, how many hours of effort will each person need to do per person per month to accommodate the contract.
And then the next tab gives a workflow for the initial assessment. And again, we've put in the information based off of kind of a general idea of what an initial assessment would look like. But of course, this is going to change from case to case and from organization to organization. So we just wanted to provide a shell for you guys to utilize to help better structure and organize your estimates. And then on the next slide, or on the next tab, is the individual care plan workflow. And it's the same shell except with coordinating an individual care plan with the member, the PCP, the caregivers, etc.
Yeah, one piece of feedback we got when we initially sent this around was on our second tab where we had how many hours per person. They were like, well, rather than I'd much rather build it up on these kinds of tabs that Mo has on the screen now, rather than just take an overall stab. And so trying to build it up, piece by piece. These tabs give you the opportunity to derive the hours of effort in a more ground up sort of way.
And then this tab is exactly what Joel said, but for a monthly case management workflow. And then the last tab we have is the revenue derivation. The top half includes the profit margin, which we've calculated in the hourly rate derivation sheet, and then below is the revenue derivation without the profit margin. And so we listed the number of enrollees starting from 25 enrollees and then going up to 500 enrollees. And we did that because at the beginning you're going to be starting pilot programs, and so you're going to start small, and then hopefully as the contract goes up and you start building rapport with the payer, you can build up the contract including more enrollees.
Yeah, one of our key suggestions is rather than trying to come to terms with a payer for a $4 million contract right out of the gate or whatever, try to just get a handful of enrollees who they and you arrive at feeling, well, these are folks we're pretty confident we can serve well and lower the health plan's costs and create sort of a return on investment that's favorable for the health plan and improve the member's health and so forth through the care coordination that your entities provide. Let's start there and demonstrate value there and demonstrate savings there, and then move up the ladder to the next set of people who, on the looks of them and the data set, maybe aren't as conducive. But if we achieve the win with Group A, then let's take our show to Group B and C until we come to some point where we don't think we're achieving the partnership's objectives anymore. But build your way up, starting from the most promising population, and then work into the onion from there. It was sort of a suggestion we have to get to a yes, to get to a more likely yes and demonstrate your value from inside the tent rather than try to just describe, throw arguments around across a table all around a very, large contract. We think that's a tougher way to get started and a lower probability way to get started.
All right, and so again, we are partnering with AIDS United to start a webinar series for the rest of the month, which delves deeper into this broad overview that we've just given. And so please go on their website to check out for dates that we will be putting up shortly, and we hope a lot of you guys join. And so now we're going to open it up to questions that you guys have.
Thank you so much. This is Sarah again. We have one question in queue, and while we are answering this one, for folks in the webinar, please use the little blue chat box or the chat icon to send us your question, and we will answer it. So we have a question from somebody in Wisconsin. They have participated in very significant care coordination benefits with Wisconsin Medicaid, and they're aware of the benefits of the programs and for the state of Wisconsin, and participate with major payers and MCOs on an FFS basis for their local clinical services. They say the payer already gets the benefits of their HIV medical home model in terms of cost savings. What else can we do to What else do we have to offer them in a renegotiated care coordination contract?
I'll just take a very crude initial stab, but yeah, we can think about this more and get back to if that's helpful. It's Ms. Burke, I think, is asking the question. So, but a couple kinds of things. One thing that Mo put up there on the prescription drug front was, if you do go into that tool and look, you'll see very different pricing for medications that may, for certain people, be equally efficacious. And so one way to help, and prescription drugs are often, much more than half of the overall cost of care now. And, we're all very looking forward to the patent expirations and the channeling down and the generic, the introduction of generic substitutes for what's been, fairly brutally priced products up to now to treat HIV. But there are today, and there's going to be growing opportunities to just drive volume towards the lower cost products and achieve huge savings on the pharmacy side, which is financially the biggest piece of the puzzle from the health plan's point of view in caring for their infected population. So that's one place where that can occur, and when that is occurring well, then your adherence-focused initiatives to help discern and help support people in adhering. This is a death sentence without adherence, and this is a manageable chronic condition with adherence. It becomes much more affordable to the health plan. They get much more excited about your adherence initiatives if the drug costs aren't through the roof. So there's a lot of things that can juxtapose and kind of cascade in everyone's favor around adherence and the pricing of drugs and the content of which drugs are being steered to when they are when they have equal efficacy. So that's one piece of it. But I'm not familiar with what you have in place on a fee-for-service basis with the state of Wisconsin or with the health plans. But the other thing we were mentioning earlier, of just getting to a broader set of people, or demonstrating your value with the neediest, most frequently hospitalized persons who are, almost crying out with their claims that their lives are broken and the hospital's patching them up, but they go back to their kind of crummy life circumstances and the tape plays again. Particularly important, I think, to engage with that population strongly and closely to help create a savings pool that you can do other things with.
Thank you. We have one more question in queue, so folks, please use the little blue chat icon to send us a question. Our next question says, one of our challenges that we face is showing the value of our nutrition, housing, transportation, and other programs and how they impact the total cost of care. Do you have some guidance for this?
Throughout, our firm does a lot of broader Medicaid managed care work in addition to the HIV project work we've been fortunate to acquire, and the whole world of social determinants, and everyone's kind of on board, I think, at this point, that these things profoundly affect people's health care, particularly low income or chronically ill or other sort of vulnerable subgroups. health status, and the cost of care, the nutrition and the housing and all kinds of things. Employment, having some kind of role in the employment arena affects your feeling of self-worth, and that can affect your health care status, and so with your mental health, et cetera. So there's all kinds of initiatives underway now to try to get at these social determinants more, but a Medicaid budget that's focused on, we're paying the cost of prescription. Medicaid can't house people within its healthcare budget, and it can't feed people within, but you can provide meals to someone for the first couple weeks after they've been hospitalized to try to help keep them on, from slipping backwards again. And you can't, there's sort of critical points in time where you can do temporary housing and so forth for someone who's homeless. Someone who comes out of incarceration, that's a critical point in their life trajectory and their health trajectory, and so holding their hand particularly closely with housing and nutrition and other social supports at those critical juncture moments is affordable, and it can lower healthcare costs. But I think your question is maybe more analytical. You do need to sort of have a data set where you have a pre and post of when before you did this and after you did it, in a control group who didn't get it, to ideally try to nail this down. But that's also part of what you can work through with a payer, is say, let's do this model with food and housing supports for these 14 people who are costing you over $100,000 a year each right now, and let's see what we achieve with them pre and post, and let's not, and let's keep a control group available who we didn't do this for, and see what those folks' costs turned out to be. That's part of what can occur in creating sort of a stair-step partnership that starts small and grows up.
And just to add to that, I believe that case vignettes also really resonate with payers and MCOs. Hearing the story behind the impact that your program has made on that individual's life, right, and the downstream impact, the resources that they were fortunate enough to receive, and how that really supported their ability to gain stability, is very telling, and it does resonate with payers. And well, sometimes there's a lack of data and the ability to capture this. Vignettes are a great way to capture that impact and the value proposition again.
Thank you. We don't currently have any more questions in queue, so I'd like to take another minute or two for folks' questions to come in. While we're waiting, I wanted to ask the Menzies group, if you were talking with an organization that is really just dipping their toe in the water of thinking about this, what are maybe 1 to 2 pieces of advice that you would give an organization as they're just starting off?
I'll try again. This is Joel. I mean, one is to just make a connection with the payer community, talk to them, and if they are just dipping a toe because they are sort of operating in a different stratosphere, it makes sense to, and I think there is some appropriate and inappropriate almost resentment of the payer community as being the bad guys, and folks that aren't the payer community, the providers are the good guys, and so forth. That's not necessarily the case, although there are certainly situations where that is the case. But get to know them, and oftentimes I think the parties will find that there is an opportunity where there's a win-win for the patient, for the health plan, for your organization, and for the providers as well. The frontline providers are often sort of frustrated that they're taking care of people when they, in the 1% of their lives when they're in front of them in their offices, but they don't have control over the very broken circumstances that they're living in the other, the 99% of their lives, and that's where you guys can really be beneficial to everybody. You have to plug in to get this all going. So I think that's be my first encouragement is just, reach out and try to get some meetings to occur. And like Mo said, an ideal meeting, I think, would be at your offices where they would see you. I think they will love you more when they really see you that way than if you're just, over a restaurant table. But any meeting's probably a good meeting and a learning experience for you guys as well if you're kind of at square one.
And adding on to that and kind of reiterating what Joel said earlier on, I think it's important for you guys to start off small and don't scare off the payer community. So as Joel discussed with housing support, take 14 enrollees, start off small and just say we want to test out a pilot program or test out just a little experiment to see how well this actually fares out, where it won't cost the payer community that much. And then I think after they do see results from that small subpopulation, I think that would also open doors to larger conversations about bigger contracts.
And, it is a very competitive environment in the space of Medicaid contracting. And so payers are trying to achieve that innovation that, we've been referring to. And they are most of the time willing to listen and be innovative with you guys as partners in our experience. And they're actually being forced to at this point because there is so much competition. They do need that community feel, and they do need to demonstrate to the state that they're able to really serve the members in the way that they can be accessed and reached. And that's not always just deploying a cookie-cutter program that a particular payer may have in another state. But it's really to work locally and innovatively with partners like you.
Thank you so much. This is a final call for questions. We don't currently have any questions in queue, so while we're waiting another minute or two, any kind of closing thoughts from our presenters?
Just an observation. Those were wonderful questions. Thanks to those of you who put them forth. But yeah, we can't get into things in depth in a 1-hour webinar, but we would encourage you guys to review the information that's now available to all of you online, and to the extent this is seems a positive thing in your guys trajectory, we'd certainly welcome your participation in the webinar series as we go. But there are lots of sides to the elephant of contracting successfully with payers, and many of those sides are local issues that we have no clue about, from where we're perched. But there are some general themes that we think can make this work, more effectively than not.
Thank you so much, Joel. So this concludes today's webinar. Thank you so much for everybody who participated, and thank you to our presenters. As we've said a few times now, there are going to be future webinars that dive deeper into this topic, so you can stay tuned on when those will be scheduled by visiting aidsunited.org/webinars or by signing up to receive our email updates. This webinar is recorded, and we will be sending out an email to all registrants of the webinar to receive a copy of the recording. And actually, a question just slipped in, so if folks want to stay on the line, I'm going to ask it. It says, we are interested in getting HIV clients due to another social service provider closing its doors. Are there any other issues we could bring up at the initial offer letter to the MCOs in our area?
I'm not sure I understand the question well enough to give a decent answer, but I guess if the MCOs were involved with the entity that's closing down, I think you'd want to understand what the terms of their relationship was. But if they didn't have a relationship with them, I think there's certainly maybe a greater opportunity if you're the only ones left who can be of help to try to at least again, sit down and have the initial meeting and, what, and one thing we'll get into is as we go through the whole series, and you can see, but we encourage that a lot of this be data driven, that the health plan has, that the health plan pull out, its HIV population and what's going on with each individual, how many hospitalizations each one has had, and sit down with you and try to figure out, like Mo said, who are the 14 or 84 or whatever people who we really think we can most help in our initial contract. But I think a key part of the initial offer involves them getting their hands around their HIV population and you then working with them. And there's specific data asks that are in our materials to try to get that train track going.
Great. And we actually got one more question come in. Do you all have any advice on including a research component in a contract if the payer seems reluctant to do so?
Everything in a contract has to be acceptable to both, so there's no magic way to get somebody to agree to something that they're, for whatever set of reasons, reluctant to. But I do think there's a lot of value in sort of what, we keep using the word pilot and starting small, but starting small and tracking very closely how that initial pilot is faring for everybody, including the member and family satisfaction with what's going on, as well as how the money trajectory has changed and so forth. But that unfortunately, there's everything's a sample of one in all these negotiations, and it's hard to speak real generally about it. But I don't know how how this is going unless you bring a lot of research and analytics to it. And I think that's in everybody's interest.
I would agree with what Joel said, and I think that there's an angle of how NCOs react to the term research, or I think they sometimes directly go to peer-reviewed journal and publishing member data in peer-reviewed journals. So there might be hesitation because of that. I think everyone uses lingo differently, and we just need to be specific and very clear that this means that we're going to evaluate our program, and not necessarily publish results with member data on these different peer-reviewed journals, because that's something that just for HIPAA reasons and other reasons that payers themselves may not be very up to and have the ability to move forward with.
We have a slogan, with the work we do for health plans that says, discover your accomplishments, but analyze your data and see where what you've done has really created a positive impact or not, and modify the or nots and expand the wins that you see there. But there's sort of a three-part path where we try to encourage payers and others to say, analyze things, say, we saw X, like what's going on here. So we've got these 27 people with 6 hospitalizations or more in the last 24 months. And then the second phase is we did Y. Okay, what did we do? What was our intervention to try to change the tape for these folks? And then look again and say, we achieved Z. What happened from the interventions we had? And then that loop just keeps playing. Then you have a new we saw X from your analysis that led you to what you achieved, and you modify the interventions as appropriate. But I think in general, payers are going to be receptive to that, not run from it. But agree with Purnima, the notion of sort of purely academic research is a turnoff to a lot of payers.
Wonderful, thank you. I don't see any more questions in queue. I think this is our last call here. We'll do 5 minutes of time. So I'll just, wait to see if anything else comes in. Okay, I think it's safe to say that concludes our webinar. Thank you so much to our presenters and for everybody who participated, asked questions, and this recording will be made available on the AIDS United website at aidsunited.org/webinars. We also will have future webinars posted up there which will go more in detail to the topics that were covered today. Thank you so much.
Thank you.